right, guys.
Everyone pay your attention, get off the couch.
Thank you, whoever brought breakfast. It's about 8:10. I know the weather was awful, so probably some folks are going to trickle in, but we should go ahead and get started. We're really excited this morning because we are going to be spending some time on diabetes care, and we have a great speaker, and Dr. Nylander was just going to introduce him.
Yeah. Good morning, everyone, and welcome to Team Review. As you all know, over the years, we've been kind of working on the diabetic care of our patients, and even in Team Review, we've been kind of really trying to break down to kind of find out, where we can improve. So for today, we decided to bring in Dr. Umpierrez, who's an expert in the field in diabetes care, just to kind of talk to us about the care of the diabetic patient. And looking forward, working with his team, we're hoping to kind of bring more resources in the clinic so that we can become a little bit better at managing our diabetic patients. Dr. Umpierrez is a professor in medicine in the Division of Endocrinology at Emory, and as well as the Chief of Diabetes at Endocrine at Emory. Please welcome Dr. Umpierrez.
Thank you very much. So we have a diabetes management program in the Emory system, and our goal is to improve diabetes care at Emory, in Midtown, and every single place that we can reach. And I think that later this month or next month, we're going to bring one of our diabetes educators to come twice a month to help you educating your patients, providing the nurses or train the nurses. We have a train the trainer program that we train the nurses and provide them. For example, there have been some places that they don't have the pens, demo pens, or they don't have enough meters to teach the person how they should do finger sticks. So small things that have resulted in great improvement throughout the system. The goal of the diabetes management program is to reduce the number of patients with hemoglobin A1C greater than 9 to less than 15%. And we just reached that. We are 14.8 throughout the whole Emory system. But we need to, 14.8 is close now to 15. So we wanted to be kind of 12, so we're better than the rest of the country. And so we have been funded to do this. And we have CDEs, diabetes educators, and we'll tell you more about it. All right. So I divided these presentations in two sections. The first one is oral agents or non-insulin agents. So the incretins and the typical patient with type 2 management. I should tell you that I'm editor of this journal, and I'm the chair of the guidelines for the American College of Endocrinology. So I kind of tell you where we are and where we're going to go with the clinical guidelines to manage patients with diabetes. So, and we're going to try to review with you the physiology and pathophysiology of type 2, and based on pathophys, how we should address and manage people with diabetes. And I'll tell you what the new guidelines would say. So I'm going to start with this. I was in San Francisco last week, and we had a meeting with Endocrine Society, American College of Endocrinology, American Diabetes Association, and the American College of Physicians to discuss guidelines and where we are with targets. So the ADA forever has said keep the hemoglobin A1C less than 7%. The American College of Endocrinology, we say keep it less than 6.5%. And the American College of Physicians says for most people, keep it between 7 to 8. So when I went to, I was in high school, I do remember that I got a C. And I told my mom, no, C is almost a B. That's right, she didn't buy that thing. So this is how I see things, that's right. And we had a long discussion, second year in a row that we meet these three institutions. So the ADA says for most people, 7 or less than 7 to prevent microvascular complications. And there's a very strong relationship between microvascular, so retinopathy, nephropathy, neuropathy, and the lower the hemoglobin A1C, the less complication there is. A says, why stop at 7? You can do 6.5. However, if you have hypoglycemia or side effects, you can back off. And both said if you have multiple complications, maybe it should be 7 to 8. I think the ACP is going to change that because in this, recently, it says that if you have patients that you expect that they're going to be around forever, so a young person with no complications, maybe you can try to achieve a hemoglobin A1C the lowest possible. So this is what the ACP says at the left. And it says you have to weigh benefits, harm, adverse events, cost. And the ADA say, well, we can do that if you choose among these different conditions. So if you have a patient with risk of hypoglycemia or previous history of hypoglycemia, maybe the first thing you do is review medications that are associated with hypoglycemia, and there are only two groups, the sulfonylureas and insulin. You can use everything. All of the other medications do not give you hypoglycemia. But if you have hypoglycemia, you should look at maybe stop the sulfonylureas, or maybe don't tight control. That's right. And this is the point with insulin. So if you have somebody, with history of hypoglycemia and you have a patient taking insulin, or you review the type of insulin, or you reach for a target, not tight control, maybe 7 to 8. Clear? Because hypoglycemia may be even worse than hyperglycemia. And the other conditions say, well, long duration of diabetes. This is kind of soft, that's right, because you can have 10 years, but you haven't diabetes from age 30, you're still 40, you're still going around for a long time. But the longer you have diabetes, more likely you're going to have complications. So that's a kind of a alert sign. Life expectancy, no question. Evidence of cardiovascular conditions and support system, resource, insurance. Those are the things that you're going to have less or more stringent in your decision making. The most important thing that all of these organizations say, you have to individualize care. So saying that, the ADA says less than 7, ACE less than 6.5, ACP depends on the patient. You are the only one with your patient that you're going to decide this patient is going to go for a hemoglobin A1C less than 7, but maybe you say 7 to 8. And if you have somebody who is demented with multiple complications, maybe around 8 or even higher than 8. So nobody can tell you what is the A1C target for each individual patient. It's you and your patient deciding according to all of these factors. Oh, by the way, anybody has any questions? Just, yeah.
This is a difficult question for me to frame, but people can get rid of diabetes through lifestyle exercise, correct? At what point, like when we're using medications coinciding with lifestyle modification, I guess at what point do we remove the medication?
So so this is a great point. That's right. And then Roy Taylor and his group and many other people. Roy Taylor is in Europe, and many people in the United States have said is that if you lose weight, your diabetes is not going away, but you stop needing medication. So if you have a patient that loses 10% of their body weight, somewhere around 50% of them would not need any diabetes medicine if the duration of diabetes is less than 5 to 10 years. If you lose 15 kilos, 75%. The problem is to lose the 15 kilos and keep the 15 kilos away forever. That's right. That's a big challenge that we have. So if I see a patient that have hemoglobin A1C or 7.2 is newly diagnosed, do I have to give them medication? So the ADA say yes. A says no. The American College of Physicians says you individualize your care. So The problem is that most people that we will see, diabetes is a progressive disease where the pancreas is going to fail. And that's the reason. So when do you start medicine? It depends who is in front of you. Yeah.
Would you make the argument that, for example, if you had somebody that was on some medicine, say metformin plus minus one of the other oral agents, and then you were able, they did lose the weight, they came all the way down, their A1C is now, we'll say, even normal, you know, the normal range, but we know that person has a predisposition for poor glycemic control. My interpretation would be, I would leave them on everything, I would take them off everything but metformin, saying, you know, we know that they have this sort of underlying predisposition and most likely going to eventually, like you said, progress. Even if they were normal, there's no risk of hypoglycemia. I would leave them on metformin, but I could see where kind of to her point that might be a point of contention depending on who you ask.
So we asked that question to the vice president of the ACP guidelines, because the ACP would say maybe withdraw some of the medicines. I mean, if you reach your goal for hypertension, you keep them there.
Right.
If you start somebody on statins and the LDL drop to 54 or 44, you say, good, that's right. Why you're going to withdraw medicine for diabetes? I will keep it at least on metformin, because metformin, the diabetes prevention program, is used in patients with pre-diabetes for years now, 10, 15, 20 years, and they still work. Yeah. So something to keep in mind is that reduction of hemoglobin A1C prevents microvascular complications, but doesn't help you much with macrovascular complications. And do have studies like DCCT and UKPDS. This is one of the classic studies that is called United Kingdom Prospective Diabetes Studies, that if you reduce hemoglobin A1C, you prevent by 20 to 40% the risk of retinopathy, nephropathy, neuropathy. And for each 1% reduction of hemoglobin A1C, you decrease complications significantly. Somehow myocardial infarction, not as much, but microvascular complications and diabetes-related complications. So 1%, it doesn't matter if you start on 10, it's 9, good, 8, better. I mean, the lower you go, the more likely you're going to prevent complications. But there is a take, that's right. If you were shooting for less than 7 or less than 6.5, you increase the risk of hypoglycemia if you use 2 types of medications, insulin and sulfonylureas. And studies, several studies, like in this case, Accord, that was in patients with type 2 diabetes, 10,000 patients. We have 180 patients here at Emory in these studies. And we shoot for hemoglobin A1C less than 6.5 using multiple medications and insulin. And this study shows that if you develop hypoglycemia, those who have hypo have increased risk of death. So there you go. You decrease complications, but hypoglycemia is a no-no. If you ask me, what is worse? Hypo, for sure. Especially hypo because it occurs at night. So if I bring your blood sugars during the daytime to you guys, you're going to have symptoms during the day. You have less symptoms during the night, especially if you're sleeping. And if you're older, even less symptoms during the night. Because the epinephrine response to hypoglycemia when you're sleeping at night is markedly decreased. So keep that in mind. So if you're using insulin sulfonylureas, pay attention to hypoglycemia in this space. So for many years, we have gone through efficacy, bring the hemoglobin A1C, and that was everything that we cared 20 years ago. Now with all of these studies that hypoglycemia is not good and maybe associated with increased admission, mortality, cost, we now have efficacy, and it's your job to balance these things. 2 types of medicine produce hypos. This is an important concept. Most people, when you are just starting to see at the beginning, a diagnosis, you can treat them with lifestyle. They do well. After a period of several weeks, months, monotherapy will be good. you are the best. If the easiest thing to do is to treat the patient newly diagnosed or recently diagnosed, they respond to everything because they have good beta cell function. And here you have, we believe that when you are diagnosed with diabetes, you already had lost 50% of your beta cell function or insulin secretion. And with increased duration of diabetes, there is a progressive decline of insulin production because the beta cells of the patient with type 2 genetically are going to undergo apoptosis of cell death. So there studies have been done, for example, people who goes autopsy series or die on a car accident, and they look at the beta cell mass, number of beta cells that produce insulin. And if you are obese, you have more beta cells that you are lean, if non-diabetic. If you have pre-diabetes, you have less beta cell mass. If you have diabetes, even less. So diabetes is associated with a progressive decline of insulin secretion with increased duration. So this is an important concept. The longer the duration of diabetes, most people will not respond to metformin and needs combination therapy. And after a few years, you're going to need insulin. So after somewhere around 10, 15 years, that beta cell is not there, or you're going to need 2 or 3 medications, and likely it's going to need insulin. So because the beta cell is not there. So what do we have for treatment of type 2 diabetes? There you go. There are 12 different types of medicine with different mechanism of action. And diabetes 101 is that you always start with metformin and you add on a second agent who has a different mechanism of action. And if that's not enough, you add a third agent with a different mechanism of action because there are 12 things. It's like going to a supermarket, one cereal, there are 20 of them. And you have to choose the one that the patient can take, and we're going to discuss side effects and adverse events. So that's it. Which one should I start? Every single association will suggest use metformin. It's $5 a month, has equal or better potency in bringing the hemoglobin A1C. We know the side effects have been around for 50 years and has cardioprotective effect. So it works by decreasing hepatic glucose production. So let me just tell you this. I mean, we can stop eating today, that's right. And we all will be alive 3-4 weeks later with just water. And the reason why, and your blood sugar is going to drop from 90 to about 70, 60, and it's going to there. Because the liver makes sugar. During long fasting, the kidneys help a little bit, like 20%. But the liver is the one who makes glucose. A patient with type 2 diabetes, one of the most important mechanisms is that the liver makes exaggerated amount of glucose. That's what is called insulin resistant at the level of the liver. So if you don't have diabetes compared to a patient with type 2 diabetes, the type 2 diabetes produce too much sugars because of the insulin resistance, because they have increased free fatty acids. Metformin blocks that. And you have patients, for example, who comes in, doctor, I don't know what happened to me. Last night, my blood sugar was 160. This morning is 220. I didn't eat anything, the liver. And metformin works there, and that's why it works so well. Because it blocks the mechanism, number one, that produces sugar during the day and night. So metformin decreases hemoglobin A1C about 1 or 2%, so good. So if you have somebody with hemoglobin A1C of 12, that's going to be short. Metformin is not going to be enough, that's right. But you have anything below 9, likely you achieve your goal. It works fast. In about a week or 2, you have the maximum effect of the patient. You don't have to wait for months. In a couple of weeks, you have it. You know, it costs $5 or free at some supermarket. Doesn't produce weight gain. Even produce weight loss in certain people, especially in the elderly. If you have an elderly person that is losing weight, metformin. It produces some GI discomfort, that's right. And it can be happen at any time. And it also has been shown to decrease microvascular complications. So This is the UKPDS again, where they studied metformin long-term for many, many years. And the use of metformin reduces the risk of acute myocardial infarction. It's cardioprotective. So, and in long term, it decreased the cardiovascular mortality and myocardial infarction. Problem with metformin in these studies, there was just only less than 500 patients, so it won't be to the category of the new studies. But that's the reason why you want to do it. Work fast, it's quick, cardioprotective, and this is why in the United States, this is data up to 2017, you see that among a million people that started on medications, here you have metformin is now prescribed in somewhere around 80%. So doctors in this country have accepted, yes, metformin the number one that we use. Disadvantages, and this is very important, GI discomfort. 50% of patients that you start metformin are going to have bloating, indigestion, nausea, here and there, diarrhea. The risk of lactic acidosis is extremely rare unless the patient has kidney insufficiency. And about 3 years ago, we changed the FDA recommendations that you can use metformin up to a GFR down to 30. Now, 45 full dose, 1 gram twice a day. Between 30 to 45, no more than 1 gram a day. Less than 30, stop it because of the risk of lactic acidosis. Are there people who has been treated with less than 30? Yes, but there are tons of lawyers in this country, so don't use them. That's right. And the other thing that is important is the GI side effects. If you start with 1 gram twice a day, that's going to be 50% of them are going to stop it. And every time you want to restart metformin, you say, ooh, don't give it to me, doctor. I couldn't tolerate that. And you start slow. Remember that treatment is going to be lifelong, so there is no rush. So you start with 500 milligrams once a day, or 500 milligrams twice a day, and you tell them to take it after the meal because that helps a lot. And there is no reason to increase more than 2 grams a day. If you do more than 2 grams, there's more diarrhea, more nausea. It doesn't help you. Remember, 45, 1 gram max, less than 30, stop it. You can also use extended release that I use a lot because several studies have shown that extended release has less side effects than the regular metformin twice a day. Yeah.
Dr. In our age now, misinformation spreads faster than information. So in the last 2 months, I've had 3 patients who told me they don't want to take metformin because of its risk with cancer. So, I know there was a time when metformin was actually being shown to have anti-cancer properties, but now it's being some controversy about it might cause cancer. I don't know what your thoughts are on that.
Metformin decreased body weight. Metformin has been tested now and is in several trials that coadjuvant to some chemotherapy has been shown to reduce the risk of cancers. I never read anything that cancer associated with metformin. Diabetes has more cancer than patients with no diabetes because most people with diabetes are overweight. And obesity is associated with increased risk of breast cancer, colon cancer, prostate cancer. So I think that the answer, I will try to count down that patient and tell them there is no evidence. I will tell them that it's the diabetes, obesity, the one that produced the cancer. And metformin has been even shown to reduce the risk of cancer. Yeah.
I think that may have been also an article about there was another contamination of a lung, wasn't it? It wasn't the medicine itself.
I was just checking. FDA is actually investigating whether there's an ingredient in the manufacturing process or is it the metformin itself that has some properties.
Yeah.
I've seen different providers use different formulations of extended release. What is if we were trying to transition somebody from 2 grams daily of metformin, what is the extended release version of that? Is it still 1 gram in the morning, 1 gram at night?
Yeah, I would use just once a day. That's the reason to do the extended release. You can use up to 2 grams. I very seldom go above 1 gram with extended release. You don't get much about it.
Okay, thank you.
So next group is sulfonylureas. That's right. They've been in use since 1950s. So 70 years. Everybody has tried them. And it works by increasing insulin release. Just if you don't have pancreas, so if you have somebody with more than 10, 15, 20 years with the pancreas doesn't make much insulin in the curve, the utilization is very little. So it's good. Here is before therapy, glucose comes down throughout the day. And the problem is that increased insulin, it doesn't matter what your glucose is. So if I give you sulfonylureas to all of you, we all be low later on today. Because increased insulin independent of the glucose concentration. And that's the difference with the new medicines, that they're not produce insulin release when the glucose is down. So, but it works well. It works fast. That's the beauty of the sulfonylureas. If I give it to you, it's going to work in a day or two. So you don't have to wait. About 75% of patients work well and bring the hemoglobin A1C down. 25%, it doesn't work. The sulfonylurea failures. It's given once a day for most of them, so it's easy to use. $5 a month, and decrease hemoglobin A1C, same as metformin. Several studies should compare metformin, sulfonylureas, same. But because it increased insulin throughout the day, they have increased risk of hypoglycemia, right? And that's the problem. And if you believe those lies or those studies that say that hypoglycemia is bad, that's the problem. So do I use sulfonylureas? Sure I do. Because 32% of my patients at Grady have no insurance, $5. But if somebody has hypos, or I believe somebody is at risk of hypoglycemia, bad kidney failure, not eating well, I stay away from it. If I have a patient that is elderly, live alone by herself or himself, it's not the right medicine that I'm going to use because of the risk of hypoglycemia. Nocturnal hypoglycemia, increased risk of fall has been shown. So caution in patients who have renal, hepatic dysfunction. And there is tons of argument during the past 30 years about the cardiovascular safety. It produced hypo, that it increased risk of death. And this is a meta-analysis of over 100 trials. And some of them lower, some of them greater. And very recently, a few months ago, we had this publication or this trial that is called Carolina. So Carolina is a study on 6,000 plus patients that were randomized or to receive glimepiride or to receive linagliptin. Linagliptin, a DPP-4, no risk of hypoglycemia. Sulfonylureas, of course, and they were studied from 1 or 2 milligrams up to 4 milligrams of glimepiride. And you see that the hemoglobin A1C came down less than 7, good. But this is the rate of hypoglycemia. So sure, definitive is increased the rate of hypoglycemia. But when they look at mortality, there is no increased mortality. There is no mild increased ER visits, but no increased rate of mortality. So David Wessler, who's a good friend of mine at the Brigham, she wrote this in the editorial. So the study says, yeah, you have to individualize, that's right, sulfonylurea, no question that increased risk of hypoglycemia, but no association risk of death. So we can still use them in selective patients. Yeah, you have a question?
So, what are your thoughts? I hear more people talking about the concern for pancreatic burnout potentially being precipitated by sulfonylureas. And then my second question is kind of to your point, sulfonylureas in essence are insulin, native insulin, that are not associated with whether or not that person has glycemic control. So two situations I think we arise a lot in our practices. One, someone who's been started on a sulfonylurea 15 years ago, and whether or not we really believe they're gaining any efficacy at all, secondary to their poor, pancreatic function. And then two, like I said, they're concerned that are we shortening the amount of time that they have native insulin production with these medicines? In other words, are we making ourselves feel better in the short term with an increase in their A1C control, but really in the long term, we maybe should be shorting ourselves to the path to insulin, which
I think that's a myth. It's not true. And giving sulfonylureas, you don't exhaust the beta cell of the pancreas. The natural history is the same. And the UKPDS follows patients up to 8 years. And the rate of decline of beta cell function was the same with metformin, sulfonylureas, or insulin. The beta cells of a patient with type 2 diabetes are genetically engineered to undergo apoptosis or cell death. And the rate of decline, the slope, depends on glucose control, maybe free fatty acids, lipids, but I don't think it is the sulfonylureas. It is true that if you compare sulfonylureas, TCDs, metformin, sulfonylureas is great, works best at the beginning, but it fails more rapidly than the other two. But it doesn't kill the beta cells. So we use sulfonylureas, or we're using sulfonylureas in this country. Here you go. This is second added agent to metformin, that's right, or any medicine. And you see that here in this country, we still have 46% of patients on metformin. So should we stop using them? Well, it's not my favorite drug, but many times I use it. Who do I use? Somebody with metformin. I have a patient who has normal kidney function, completely normal. It's a little chubby, so it's insulin resistant. Recently diagnosed diabetes. I use it. I will not use glyburide ever, because that produces more hypoglycemia. But I can use glyburide, 1 milligram, 2 milligrams, 4 milligrams. Max dose 8 milligrams. Very seldom I go above 4. You can use glipizide XL, has less hypoglycemia than the short-acting. So you're still using it's $4. So many patients, that's what you have to do. If somebody develops hypoglycemia, then oops, there you go.
Can you say something again about how you go about choosing your sulfonylureas?
They're all the same. All increasing, the mechanism of action is the same, but glyburide has more hypoglycemia than glimepiride, that is called second generation or third generation sulfonylurea. I think that glimepiride or glipizide XLs are the best thing for me. So TCDs, that's right. How many of you still use Pioglitazone Actos? Well, I use it now. So 1 out of 3 Americans with type 2 diabetes 20 years ago was on this medicine. There were 3 in the market. 2 of them are out. There's still 1 survivor, that is Pioglitazone. So it works by improving insulin sensitivity in muscles. So clear glucose from the circulation. It's as potent as metformin. Reduces hemoglobin A1C 1 or 2%. It doesn't give you hypoglycemia. It's even when you give Pioglitazone, levels of insulin reduces. It prevents diabetes better than metformin. It's once a day. And it's shown that it has cardiovascular protection and stroke protection. So great medicines. But the problem is that rosiglitazone that was taken off the market some time ago was associated with increased risk of myocardial infarction. And there is increased risk of heart failure or edema or water retention. And the problem with Pioglitazone is that it produces weight gain. So if 80% of our patients with diabetes are already overweight, obese, and you tell them this medicine could make you gain a couple kilos of between 1 to 4 kilos, ooh, don't give it to me. That's the problem that it has. But if you have a patient with fatty liver disease, with diabetes, the drug of choice.
Even if
The other,
they're obese?
I'm sorry?
So what if they are obese?
They are
and
obese, they
fatty
still
liver
work.
disease?
With fatty liver disease is the only medicine that have been shown well, not the only. The first medicine that was shown to decrease triglyceride concentration in the liver, despite that you gain weight. So the other problem that it has is slow onset of action. You have to wait up to 12 weeks to see the maximum effects. The other problem is water retention, edema, and is contraindicated in patients with heart failure requiring medications. And the other thing that in the last few years, which really put this medicine down on the list of choice to me, is that in postmenopausal female is associated with increased risk of osteoporosis and bone fractures. And we did several studies on this several years ago. And the mechanism is that increased fat. So the bone marrow cell, the progenitor cells, instead of going to an osteoblast or bone forming cells, the bone marrow is full of fat. And that's the reason why they decrease, bone osteopenia in this patient. So there is also, in some countries like India, like Germany, has been associated with increased risk of bladder cancer. The FDA in this country hasn't shown that, so we still use it. So do I use it? Yeah. So the dose is 15 to 45 milligrams. So if I'm going to use it, I use 15 milligrams and never use more than 30, never. And with 15, the weight gain is minimal. The risk of heart failure is minimal. The risk of bone problem is minimal. And it's a $5 a month medication. $5. So you can use 3 drugs with less than $10. Metformin, some of the sulfonylureas, and Pioglitazone. So, but if you ever use it, don't go. In India, they use 7.5 milligrams. 15 milligrams, sometimes that's remarkable well, especially in those very insulin resistant patients. But they gain weight. So what about the DPP-4? That's right, they're commonly used. There are several now on the market. They work well, no weight gain. You don't have side effects. Very little side effects. Somebody says they have nasopharyngitis, but in Atlanta, everybody has with the allergies. The problem, cost. Somewhere around $200 to $300 per month if you don't have insurance. The good thing, sitagliptin, Januvia will be generic in a year.
Really?
Yeah, the patent is already expiring. But these companies always find a way to keep it non-generic, but it's going to be generic. So it can be used monotherapy, combination therapy. They work by blocking this enzyme that destroys the GLP-1, right? And GLP-1 is the enteric hormone that increases insulin release and suppress glucagon. So decrease hepatic glucose production. And DPP-4, all of them are the same. All of them are the same. Increase the concentration of endogenous GLP-1 by about 2 to 3 folds. And by increasing GLP-1, you increase insulin release and you suppress glucagon. And glucagon is the hormone that makes the liver to pour sugars. So you decrease hepatic glucose production. So increase insulin, decrease glucagon, the blood sugars comes down. Makes sense, that's right. A lot of discussion, which one should I use? They're all the same. They're all the same. So here you have saxagliptin, linagliptin, sitagliptin. Sitagliptin is the #1 prescribed here in the United States, the first one in the market. But it's weak. So the reduction of hemoglobin A1C is about 0.5, 0.8%. So it's great if you use it with metformin. Great, yeah. And then together with metformin, you can start seeing a 2-3% reduction in hemoglobin A1C. But if you have somebody with hemoglobin A1C of 9, you know you're going to be short. And they have low dose, high dose. It's about the same. A good thing is cardiovascular neutral. It doesn't kill you, doesn't give you a heart attack, or it's just cardiovascular neutral. But it's 0.4. So if I have a patient that I'm seeing in the clinic, metformin, and I'm going to use another drug, for $300 a month by 0.5% reduction in hemoglobin A1C is not very appealing to me. So who do I use it? In the elderly. In the elderly. Best medication combined with metformin. No risk of hypoglycemia, reduction in hemoglobin A1C, 1 or 2 or 3%. So you get in less than 8, you're okay in the elderly. A patient who has kidney failure, you can use all of the DPP-4 even in dialysis. So if I have a patient with kidney failure, cannot use metformin, cannot use sulfa, and doesn't want to give insulin, DPP-4 are good drugs, even in dialysis. What about GLP-1? So, a lot of news, that's right. We have daily use of GLP-1 and long-acting or once a week. And exenatide, exenatide they're not in the market anymore. And liraglutide is the only one that you have to give every day. And all of the others are once a week. I apologize, here is not semaglutide, is the other one that should be here. And so I tell the patient, you want a shot once a day or once a week? Most people say once a week, that's right, because they work exactly the same. They increase GLP-1 levels because you're injected. And your increased GLP-1, like DPP-4 increase like 2 or 3-fold, you increase this by 8 to 10-fold. So they're much more potent, and therefore they increase insulin, suppress glucagon, and also decrease the gastric emptying and decrease appetite. So it's associated with weight loss, most of them. So a lot of discussion in the literature. Which one is better, best? They're the same. Here you have the effect. Yeah, one's a little better, but in general, the lower dose is about 0.8. The higher dose is about 1.2%. It produces weight loss. So there are studies that people go and say, here you go, all you can eat buffet, and you are reporting, and then you start therapy, and then you come back, all you can eat buffet, you should eat much less if you're taking this medicine, because it decreases appetite. So patient with diabetes has polyuria, polydipsia, polyphagia, that's right, the 3 Ps. It's not a mistake that people with diabetes eat a lot. So this agent has been shown to decrease appetite and produce weight loss about 1 to 4, 1 to 3 kilos. So it's great, that's right. But it's not a weight loss medicine at the dose that we treat diabetes, because 25 to 30% do not lose weight. And after a few weeks or months, you plateau and don't lose any more weight. So I won't tell them, I tell them that they may lose a few pounds, but it's not a weight loss medicine. So why do we use now GLP-1? Because of the cardiovascular protection and the renal protection. So there's several studies now, several studies with several of these GLP-1, like they have shown to reduce the risk of heart attack, stroke, and cardiovascular mortality. The first one was called the LEADER trial. They used liraglutide, so patients were taking all the medications, hemoglobin A1C between 7 to 10, and they were given placebo or 1 injection of liraglutide per day, followed for 3.5 years. And it shows that the risk of cardiovascular death, non-fatal myocardial infarction, and stroke was significantly reduced. For the first time, we were able to see that you can improve cardiovascular mortality in patients with diabetes. The other medications do not. Cardiovascular death decreased by 20%. The another trial was sustained. This is semaglutide. And you see a significant reduction of cardiovascular death, myocardial infarction, and stroke that's somewhere around 25%. Look at here, stroke. Look at here, myocardial infarction, 25%. So if you have a patient who is at high cardiovascular risk or already have some kind of ischemic heart disease, these agents are incredibly beneficial. But what's the problem? About 30% have nausea. It usually decreases within a few weeks, but you have to tell the patient you're going to start taking this medicine and you're going to feel nausea. You may even puke, but it's rare. You may even have a few loose stool here and there, but it goes away. But if you do not alert the patient, they will stop it. The other thing is injectable, and you cannot use it in patients with pancreatitis because GLP-1 has been associated with increased risk of pancreatitis, although very minimal, but in those who have previous history of pancreatitis may be a problem. And in animal studies, have been increased the proliferation of medullary cancer and cannot be used in people who have history of medullary cancer. You can use it in patients who have thyroid, papillary, follicular cancer, but not. So what are the problems? Cost, $600 to $800 a month. It's injectable, and you do it once a week, once a day, but you have to take injectable. Last month, the FDA approved the first oral GLP-1, that's semaglutide oral. And the study shows that oral semaglutide is as good as injectable liraglutide with the effects on hemoglobin A1C and weight, and also on cardiovascular protection. So what's the problem with oral semaglutide? It's $5,500 a year. It has to come, I don't know if you receive these pharmaceutical reps here, but if they tell you, it's kind of, I never use it yet, but I know that you have to take it with just half a glass of water, with water. If you take it with meal, you do not absorb. It comes in a package with blisters. So because it cannot be exposed to light, daylight. So you cannot put it in a little box like many of my patients do. And you take it, they cannot take any other medicine. So for half an hour. So if you take it with too much water, it works by attaching to the mucosa of the stomach and they have absorbed. So too much water, the pill will get floated around. It doesn't get attached. I don't know. But it works. So for those people who don't want injection, now we're going to have GLP-1 oral. The first one, I'm sure they're coming more. But it has to be blister. You start on 3 milligrams, go to 7 and 14 milligrams, and it works very well. And the studies showing that it's even better than SGLT2s and other medicines.
Excuse me, just a couple of comments.
Yeah.
You mentioned cost. Cost is obviously important. This particular group of drugs. The reason that they are particularly liking is the decrease in insulin burden significantly as well in the patient that you have them combined. But the drug companies I have a few patients that the drug companies are literally giving them biological feed. And I found that even potentially triglyceride might be that.
Yeah. And there are programs for patients that need help, and you can request free drugs and support for months. The problem is that we don't have time to go and get all of these special programs for patients. I don't have time. So.
No, the motivated patient gets that.
Yeah.
Tell them about it.
And I'm going to talk about cost in a minute, but I can tell you this. I mean, I'm the chair of this guidance, okay? And I do believe that cost is a big deal. But if I tell you in one of these politicians who talks about free drugs for everybody, medication free for everybody. And if every single medicine costs $5, all of it, which one would you use? I mean, when would you use sulfonylureas? Maybe no. TCDs, maybe no. That's right. You still use metformin, but these are no medicine who prevent heart attack. Or if you have a patient with cardiovascular complications, it works very well. And I'll show you in a minute the kidney protection. Let's move to SGLT2s. That's right. So if your blood sugar goes up above 180 or 200, a mechanism of defense of the body, how they protect flush sugar in the urine. That is this. is physiologically the way that we prevent severe hyperglycemia. And the reason why we flush sugar or reabsorb sugar, and if you don't have high blood sugar, you never have glucose in the urine. Because if you spill glucose in the urine, you're spilling calories. 1 gram, 4 calories. So you will go away, that's right. So this prevention of glycosuria or lack of glycosuria is controlled by the SGLT-2 mechanisms. 90% of the glucose is reabsorbed. So the pharmaceutical company and smart people in this world say, what happens if I block this thing? So you block the SGLT2s, you have glycosuria. And if you're spilling glucose, your blood sugar comes down. And because you're spilling glucose, you're spilling calories, your body weight comes down. So simple, that's right. But if you have a lot of sugar in the genitalis area, in the urine, the payback or the worst thing is that you can get, fungal infections, UTIs. So works fast, that's great. Reduces hemoglobin A1C about 0.8 to 1.2, but not insulin mediated. So it doesn't give you hypo and produce weight loss, and for sure have cardio protections and renal protection. In this country, there are 4 in the market. Canaglifloxin, dapaglifloxin, empaglifloxin, and ertuglifloxin. Which one is better? They're the same. Low dose, high dose, somewhere around 0.8 to 1.2. Higher the hemoglobin A1C, the greater the reduction. Weight loss, about the same. 1 to 3 kilos weight loss. Not everybody loses weight. So you cannot tell the patient, this is going to make you lose weight. This may be associated with some weight loss or may help you to lose weight if you do diet and exercise. That's what I tell the patients. The best thing, they are now, I just have 3 here. 3 studies, 4 studies now that are showing their cardiovascular protection. They reduce the risk of heart attack, stroke, and cardiovascular death by about 20%. This is with CANA, this is with EMPA, EMPA-REG, CANVAS, and the CLEAR studies, all shown cardiovascular protection. And more importantly, in patients who have low ejection fraction, heart failure, I'm sorry, there is a 30–40% reduction of heart failure. These medicines were approved last month by the FDA for heart failure in patients with and without diabetes. Now we have the cardiologist at Emory who wants to have this thing everywhere because it reduced heart failure readmission. It reduced readmission and death by 30%. If you have a patient with heart failure and it's not on SGLT2, think twice. I think it's poor practice. Maybe malpractice one day. Because you are, but the problem is $300 a month. So not everybody can have it, that's right. But that's the way it is.
Is that for reduced and preserved ejection fraction?
The study in the New England that was approved is for heart failure, reduced ejection fraction, less than 40%. The preserved ejection fraction, nobody knows how to treat them, that's right. Maybe it's blood pressure mediator or things like that. Yeah, but it works also in the preserved ejection fraction. The other thing is that it has renal protection effect and decreased proteinuria. It decreased progression of renal disease. Oops. So if you have somebody with albuminuria, you use ACE inhibitor, that's right. But many patients who have ACE inhibitors still have an albuminuria. These agents decrease albuminuria. So I think that SGLT2s are excellent. The problem is too much sugar in the genitalis area in the urine, increased risk of infections. Never, if you're going to have a patient on SGLT2 who's not going to be eating or wants to do a ketogenic diet, no, because they can develop diabetic ketoacidosis. In the patient that you stop eating today, you will develop what is called starvation ketosis. These agents increase ketones production. And we have over 15 cases in the Emory system with type 2, type 1 with DKA. So if somebody's going to go for bariatric surgery, they're not going to be eating for several days, stop it 3 or 4 days. Is somebody going to have surgery? They're not going to eat for 3 or 4 days, stop it 3 or 4 days before surgery because of the risk of DKA. And the problem is high cost, that's right. So, I know, give me a second. So what I told you so far, you have efficacy, great. You know that most of them work. Safety, hypoglycemia, and the real way that we think now, the recommendations, is that we have now cardiovascular protection, renal protection with GLP-1, SGLT-2. Yeah.
It's all that starvation that actually tends to make people to that DKA. I mean, obviously it's accurate.
Yeah.
But interestingly, I read about a patient who developed DKA, newly started on glucosamine, who went on a cruise. And I know that clearly there is not a starvation diet.
Oh, no. All right, so starvation never gives you DKA. The starvation doesn't drop your bicarbonate less than 18. But these agents do. And many times they have what is called euglycemia DKA. So instead of having glucose of 400 or 500, the glucose is around 200. That is the problem with these agents. You see it, especially around surgery, when somebody doesn't eat. So don't use it if somebody doesn't eat. Yeah.
So, in your experience, how much carb, percentage does somebody have to have? Because obviously, I don't often or really ever, with very few exceptions, recommend like a true ketogenic diet, but a lot of people are on very low carb diets. If someone's having even a moderate or mild amount of carbohydrate consumption, is that enough to sort of avoid this euglycemic DKA, or is even someone who's on a very carb restricted diet a concern for that? Because I did read about it in terms of a true keto, but there are people who kind of flirt with it. Is that somebody you're still worried about, or is
yeah, a true keto diet is extremely hard to do in the way that you just have to eat no more than 20 grams of carbs per day. So 80 calories a day of carbs. You cannot even eat lettuce and tomato. Meaning, a true keto diet is extremely hard. I mean, it's the best thing for diabetes, but it's harder to do it. If you eat more than 500 calories a day, you shouldn't be ketogenic. So 500 calories a day is easy to yeah.
Intermittent fasting diets are things that I've heard patients talk about in diabetes treatment.
Yeah, intermittent fasting.
Mm-hmm. Obviously not good with this medication.
But intermittent fasting is that you skip a meal that you have to have. It works very well. So intermittent fasting is that you have to eat for day or night. So for example, you're in Muslim and you're in Ramadan that is coming next month, you eat at night, but you eat during the day. What we do in this Western society, we eat the whole day. That's right, day and night. But intermittent fasting means that you skip one meal, so you have at least 12 hours of fasting, and that has been shown to produce improvement of diabetes control and weight. I like it. Yeah.
One quick question about the SGLT2s. For patients with GFRs between 30 and 45, what do you typically recommend? It seems like it changes depending on what country.
Yeah, so when they first came above 60, they dropped 45. Now we know with the credence you can use up to 30, but the effects in reducing blood sugar is less with less than 45. So 45 and above, use them. 30 to 45, you know they're not going to be as effective, but still may have the cardioprotective effect. Yeah.
Would you talk for a sec just about your perceptions of what is a common recommendation, which is multiple little meals all day long, with
Yeah, only that's a mistake. This is when we 20 years ago we had Metformin, Sulfonylureas, and NPH for 70 days. So it was terrible. All of them produced hypoglycemia at Metformin. So when we taught patients said you have to eat snacks because to prevent hypoglycemia. And now we have medications that don't produce hypoglycemia. Insulin produces less hypoglycemia. Only baby has to eat every 3 hours. We don't, and if you eat every 2 hours, okay, small meals. If I eat with my wife, small meals to me may be a large meal to her. That's right, to snacks with your friends. I mean, there are guys, I mean, when I was there, I ate twice what I eat now. It's not small meals. If you have a patient with a BMI above 30, no, it's not small meals. So we don't recommend frequent meals anymore. We don't recommend snacks. We recommend snacks for elderly people who have history of hypo with type 1, with hypo and things like that. For some certain workers who have non-hours of work. Yeah, stop doing that. Yeah.
I just have a question. You mentioned like when people fast for other reasons all day long, the SGLT2s are still fine for them. Do they get volume depleted during the day?
We just submitted the new recommendations of Ramadan. We do the Ramadan guidelines every 5 years. There have been 2 or 3 recent papers using SGLT2 during Ramadan, and it appears to be okay and safe. We're done in Saudi Arabia, those countries. Yeah.
Just have a question on this slide. You have CVD leader and then duration. Can you just elaborate what you mean?
Oh, that's the name of the study with semaglutide. But there are many other studies that I didn't put. So let me just finish with the guidelines. What did they recommend? This is very important. This is the recommendation of this is what is coming next year or later this year. If you have hemoglobin A1C less than 7.5, just use one drug. If your hemoglobin A1C is greater than 7.5, we're recommended to use 2 drugs. If you have less than 7.5, you start with metformin. 3 months later, you're not at goal. You can choose whenever you want. So why GLP-1 and SGLT2s? Because I think that you agree with me that diabetes is a cardiovascular equivalent. That's right. I mean, it's high risk. I mean, I do understand cost. I truly understand cost. But if you use DPP-4, don't have cardiovascular protection, TCDs, you break your bones, you get fat. Sulfonylureas, hypoglycemia, and insulin nobody wants. So we suggest this, knowing that cost is an issue. 3 months later, you do triple therapy. Now, if the patient has hemoglobin A1C greater than 7.5, we are recommended 2 drugs to start. Now, if I have a recently diagnosed diabetic, well, I still have good beta cell in the pancreas, metformin alone. But if I see a patient who has diabetes for 10 years, 5 years, come to the clinic, we're not going to use 1 drug, we'll use 2. And now there is a study that I don't know if you read it, but you should. It's called Verify. We're published in Lancet, I believe. Yeah, a couple months ago. And what this study says that even with hemoglobin A1C of 7, if you start on 2 drugs, the study was done in Europe. So they use vildagliptin, that is one of the DPP-4 that we don't have in metformin. You prolong the normal glycemia. And there are several studies have shown 2 drugs better than 1. Saying that, ADA says hemoglobin A1C greater than 9, you use 2 drugs. I don't know, whatever. Keep in mind this. If you start 1 drug, let's say metformin or sulfonylureas, it works well at the beginning. But if you follow this patient 3, 6, 9 years later, very few people are under control. It doesn't matter if you use metformin, sulfonylureas, so it doesn't destroy the beta cells. So when do you start 2 drugs? At the beginning, or you wait until you fail? I think that this is the way we've done medicine. You give 1 medicine, you fail, I give you 1 more. Fail, 1 more. Fail, 1 more. What we call trick to failure. So why? The Verify says that you use 2 drugs from the beginning to prevent this zigzag. So we are going to recommend 2 drugs for sure. The final comment is this. If you have a patient with heart failure, with ischemic heart disease, hemoglobin A1C of 7.1, 7.2, you should use a GLP-1 or a SGLT-2, especially if you have heart failure. Especially if you have heart failure. And if you have kidney disease, if you have somebody with proteinuria with GFR less than 60, use them because they've been shown to prevent the progression of kidney disease. And of course, cost is an issue, that's right. And if somebody has no insurance, they pay out of their pocket. You have Metformin, Sulfonylureas, DCDs, human insulin. ADA changed last year. I was a member twice of the standard of care. And 2 years ago, we used to say this, that's right, with the ADA. You start Metformin and then you choose whatever. You remember, you've seen this all the time. Now we say it differently. You start with Metformin, 3 months later, you are not at goal. And then you say, you have to ask that my patient has cardiovascular disease, so heart failure or ischemic heart disease. And if the answer is yes, here. If the answer is no, so you have a 40-year-old, you're chubby, you still can use everything. But if you have cardiovascular disease or heart failure, you should consider using GLP-1 or SGLT-2. If you have heart failure, GLP-1 doesn't reduce admission for heart failure. Clear? SGLT-2, yes. A GLP-1, no. But if you have ischemic heart disease, so a history of heart attack, a history of stroke, you can use either one of them. So who do you choose? Whatever you want. Both are effective. You ask the patients, would you like 1 injection a week or 1 tablet a day? There are several studies, and I'm going to, no, I talked too much. There are several studies, for example, the population studies, and you ask young females, I consider young female less than 65. You want once a day or once a week? 60 to 70% of them would say once a week. Because women multitask. They work, they take care of the kids, they cook, they do everything. Boys, they don't multitask. Elderly men would say once a day. I don't forget. So if I have a young female, I'll tell them, what do you want? Once a week or once a day? Okay, all of you, how many of you women would say once a week versus every day? There you go. It's not you. They have been population studies. So when you recommend this to your patients, you know what they're going to say. It's easier to sell it once a week. But if they have heart failure, don't recommend GLP-1. Recommend SGLT-2s. Cost. That's the main problem. Your medicine is $2, $5, $4. But look at the cost of these new agents. My goodness. But again, when you make guidelines, I mean, if you have insurance, that's right, you can do it. Now, Medicaid, Georgia Medicaid has said, DAPA, most of the programs recommend now exenatide once a week. So there are some emails and some websites that are going to be given to you already we have been shared that you can look for this. The problem is co-pays, that's right. That's the big deal. I mean, January, February, the problem is co-pay that is so high to get these medicines. But I hope that one day, but I don't know. I mean, so what we have learned, we have 12 different medications with different mechanisms of action. Some work in the pancreas, some work in the liver, some work in the kidney, some work in the peripheral tissue. You have to choose. All of them work. All of them work. It doesn't matter which one you choose. All of them fail. All of them fail. And with increased duration of diabetes, multi-medication or insulin should be considered. And many years ago, in the 80s, 90s, up to 2007, we only care about efficacy. Then, Accord, Advance, VADT, these trials that say hypoglycemia kills, whoops, we pull back. And now that's your choice. And now I think the future is going to be cardiovascular and renal protection, because these patients should do much better with this new medication. The copy of these slides are here. That you can have. I couldn't send it to you because I don't know why it became very large, like huge. They didn't check it. So I think I tried to send you by Dropbox. I used Dropbox. Good. You got it.
Let's hear a round of applause for Dr.
We didn't go to insulin, but
You're gonna come back.
Huh?
We'll have to have you back.
perfect. The slides are here for insulin. How do you do insulin?
We recorded the lecture as well.
Huh?
I'm just letting you know we recorded the lecture.
Oh, good.
No, yeah. Okay, let's take 3 minutes, and then we have a lecture from Belinda. At the
Yes.
bottom. Yeah.
We can take 5 minutes.
5 minutes.
What?
Andy.